Hi, everyone. Good evening. My name is Annie Benzie. I am chair of the Fellows Committee for the SSAT Complex GI Surgery Subcommittee. We are very excited that you're all here and able to join us this evening for our first Grand Rounds session of this academic year. We have a great and very interesting talk up tonight. And it is a pleasure, and I'm very grateful to introduce our moderator, Dr. Eric Pauly, who is professor of surgery as well as chief of the Division of Minimally Invasive and Bariatric Surgery at Penn State. And he is going to introduce our fellow and just give us a little overview on this topic. Dr. Pauly, floor is yours.
Hey, thanks very much. Thanks to you and to the folks from SSAT for asking me to moderate this event. It's my first time doing one of these for SSAT, and so we'll learn along the way here. As you can see, there are some comments in the chat for the fellows who are joining us. We'll make this as interactive as possible. If you have questions, please feel free to throw them up in the chat or obviously raise your hand at the end when we're doing some in-person discussion, and we'll try and get through everybody's questions as the afternoon goes on. Our fellow speaker for the day is the current fellow at Atrium Carolinas Medical Center, Innocent Birangiro, and he's going to spend some time talking with us today about evidence-based approach to ventral hernia repair in the preperitoneal space. And I would say that of all the fellows who could talk on this topic, he's situated at the right spot for it, because Carolinas, as many of you may know, sort of pioneered the modern way that we are fixing hernias. Dr. Henneford, who recently left Carolinas, spent many years kind of turning hernia surgery from something that anybody could do into something that most people want to do, but maybe not everybody should do. And along the way, he and his former trainees, who then spread out across the country, really revolutionized the way that we think about fixing hernias. And Innocent is going to go through, I think, in a pretty stepwise approach, some of the thought process to how they currently fix hernias, kind of how did they get to where they are? And we'll talk a little bit about some of the things that I do differently than what they do, and we can maybe hear your experience around the country as other fellows as well. So with that, I'll turn it over to Dr. Birangiro. Innocent, the floor is all yours. Go for it.
Well, thank you so much, Dr. Powell, and thank you, Dr. Benzie, Beverly, and everybody from the SSAT that has made this possible. It is a huge honor for me to be part of this and have this platform. As Dr. Powell kindly said, this is the first, not just the first to be presenting for this series, but it's my first time giving this talk, so from time to time, feel free to jump in questions, or I do not have ability to see the chat for you to see my screen in a reasonable manner. I had to make it where I cannot see the chat, but any audio feedback, I will be able to get it. So as much as I would like to have some financial disclosure to make, so far I do not have any. And if, depending on where you stand, yes, I did use artificial intelligence for some of the part of this. I will show you specific slides, but strictly just as you would use Google or any search engine. And I tried for some design, since there is nowadays image and video generating models. So in 2025, what is the source of evidence? What is the source of information? I thought if anybody would be a nation as advanced as our nation, would be the source of the truth. We have so much scientific advancement. But when I went, I was trying to find the NIH. Somehow I ended up at the health military website. I thought, wow, this is even better. The evidence must be robust. But for reasons beyond our talk today, uh, I have to rely on the giant, uh, big but incredibly soft hearts that have made this possible for me to have access to this data, but also to their training to learn how and why they operate. So I'm preaching to the choir. I have no doubt that the hernias in the U.S. They never fix themselves. It's a natural thing to happen. Almost 250,000. We fix them every year, and of those, the rate of recurrence it's not insignificant. So we are in the ever non-ending quest, searching for ways to minimize or distribute any tension and do it in a way that will improve patients' quality of life. Uh, so we are fighting nature. They are naturally weak areas of our bodies. As you know, from the earliest weeks of gestation, uh, if we end up with whether it's just the umbilicus, or whether it's in the pelvis or in the chest, anywhere there is an opening and whatever content that is herniating through the non-natural opening, that will be the hernia, whether it's ventral, whether it's thoracic, or even you might even add the brain, any organ essentially. Uh, so now we take these are the weakest areas, but they're already known. And when you think about it, where do we make incisions? I'm not calling for let's start making some paramedian laparotomies or anything like that, but to think of the ways how, given a patient all they have is their body, uh, how can we enhance or optimize the patient so that the areas that are naturally weak they can be strengthened in as much as we can. Uh, Whenever I think about these images, I almost I start dreaming about second year of medical school. So I will spare you that. I kind of jumped ahead of myself by mention defining what a hernia is. But primary, it's just if it's spontaneous, and there is a Latin name that this is supposed to, if it's related to a scar that is for either trauma or a surgical scar. That's the point of herniation. Then it's an incision. And the division, I think this is much more for uh, communication to know, and even for research purposes. But as you can see, over the years, when we're looking at our outcome, we have an easier way to classify which, if it's an incision or hernia, what were the size defects, and the more variables that we can generate, the more of an informed decision that we can make. So before I even run, I know I barely started talking, but I'm just checking in to see if anybody there is anything that they want to add before I go into the ways the hernias can be reinforced. This can be a talk in itself. So this will be almost the entirety of what
Hey,
I say on this diagram.
Innocent, I might chime in here for a minute and just kind of play off of something that you said, which is you said that you are not advocating for us to make paramedian incisions as a method of hernia prevention. Did I hear you correctly?
Yes, sir.
I mean, the European Hernia Society, in their guidelines for hernia prevention, says exactly that, that the literature on hernia formation after surgical incisions suggests quite heavily that paramedian incisions are a great way to prevent hernia formation. And so this is a question that I commonly ask my trainees. We've got these guidelines that say we should be making paramedian incisions, and then we all go and make midline laparotomies. And why is that the case?
I
mean, I'll answer it. I mean, because we care more than just about hernia formation, right? Like, hernia formation is one bad outcome following a laparotomy, but also a paramedian incision may not give you a good exposure, right? If you're Dr. Jerariah and you're doing a liver, you're going to make some sort of a modified Makuchi incision so you can have great exposure to the liver. And when that happens, the lateral portion of that incision doesn't get a hernia, but the midline portion, that's where they happen. But you also get more pain and you get muscle incisions that result in denervation problems. So if you only care about hernias, and we're hernia surgeons and we care about hernias, then paramedian incisions are not bad. But if you care about all the other bad stuff that comes along with potentially off midline incisions, you've got to keep that in. So I also do not advocate that, but I also recognize that the guidelines state this is probably what you should do if you only care about hernia formation.
Dr. Polly, I'm going to jump in because I actually just want to give you a little historical background. Dr. Biringiro, forgive me for my pronunciation. Having a long name, I try to pronounce things correctly. When I trained at the University of Chicago, we were very in tune with Mayo and Michigan with transverse incisions, believe it or not, because of the risk of hernia formation, especially in IBD patients on steroids. So we used to do directly below the umbilicus transverse, which to me at this point sounds crazy, but at that time that was our routine thing. And as Dr. Poli correctly pointed out, I had the wonderful opportunity of getting into the spleen, doing a total abdominal colectomy and having to do a splenectomy from that, which was thrilling. But we did it. But I totally agree with you. Exposure is not exactly great with some of these approaches.
Well, thank you so much, both the commenters, for that enriching discussion. So it's fantastic to have not just to know about what the numbers say, but the implications for it. So of reinforcing these, whether it's naturally or whether it's artificially weak areas where the hernias form. I think of the simplest ways as much as possible. One is, so far we are not able to recreate new bodies. Whether it's the abdominal wall, which is what we are mostly talking about today, and on the other extreme of that, what can we do to replace this? So it's a large spectrum involving engineers, and from time to time, the surgeons in the past, we might have been the last to arrive on the table. If you ask me exactly how, like some of these molecules, if you sent me in a lab, you gave me unlimited budget, can I reproduce some of this? Because I realize I cannot, I trust my colleagues on the other side of town that due diligence has been done and that what is preached here is actually the way it is. So from natural, from absorbable to non-absorbable meshes, I think the future will kind of touch to it to the end is beyond the physical material. What else can we look up to or use as a substitute? There are multiple factors why I'm not commenting on a specific mesh because depending on where you are and what time it is, you might have a different answer. So this is at least here at the Carolinas, what we've been looking at is whatever material that you have to reinforce the abdominal wall, where do you put it? Over time, we know suture repair, they come apart. It's a matter of physics and time. If we put the prosthesis too far close to the atmosphere, it will become exposed and we will get wound issues. Intraperitoneal it's on the other end of the spectrum, but then we have adhesions and uh, catastrophes with interaction with the bowel. I think the quote-unquote retromuscular, this is the, the Reeves stopper classically. I think we were trying to move away because is the rectus muscle fibers and it's a little bit traumatic. So what's the evidence of what we're doing the preperitoneal plane? Why not the other options? Uh, well, it's self-evident through the data that we are discussing today, but also these attribute we have attributed to the outcomes that we see. So we want a piece of the ventral wall is pliable. We don't want to make concrete. We want something that, if possible, it can stretch without being too plastic that it will fracture, which is the case for lightweight mesh. They, they're great. They can bend. They can incorporate well. But then, if you see the patient at 5 years, well, 2 years, I don't know how many surgeons are following up for that long. You find those issues, and then if you the super heavy, if there is such a term, uh, then you're creating an abdominal wall that is concrete. Some of them, if you was at the meeting, you know, once it's explanted, you can make it's essentially concrete. So I will ask these to the fellows. You have 63 years old gentlemen. They have had laparotomy for one reason or another, and now they're on their third incisional recurrence hernia. And this is the defect that you have. What else do you want to know?
I would want to know position of previous mesh.
100%. Anything more?
BMI and smoking status?
Anything missing?
What prior repair methods were used?
Yeah, so yeah, I agree. You want to know the mesh location, and because this is going to affect your approach. Is the mesh still there? The prior infected mesh, has it been removed completely? Because if it's still there, you can put in maybe short of holy water. It has to be explanted. So,
Innocent, if I could just pop in for 1 second here,
please.
and I'm going to tell you something that I think you probably all know, but I'm just going to articulate it aloud, which is operative notes are terrible in general. We as surgeons do a very good job, very poor job reflecting the things that we do in operative notes. And any study you'll ever see on operative notes, from something as simple as gallbladder surgery, you will find that if you watch the video of the operation and if you read the operative report of the operation, while they are similar, they are not the same. It's kind of like, when you're reporting a crime and you're like, it was a blue car, but the car was actually like, purple. Okay. Like it was a car and it was sort of the similar color. Our operative notes are very much like this. And in an era before hernia surgery becomes a science, those notes are pretty terrible across the board. And so you might get a note that says we then placed mesh, and it doesn't say what kind of mesh, and it doesn't really describe the plane that the mesh was put in. We reviewed op notes of patients coming to see me for hernia surgery, and the most commonly used mesh in our area locally is a mesh called appropriately sized mesh. Okay. Which doesn't work, by the way, because everybody that I meet who has that in has a hernia back. But people not only don't describe it well, many people don't know the names of the meshes that they're using. Okay. And so you get a wrong name here, or a name that's sort of like the name of a mesh, but not really the name of an actual mesh. Okay. So thing one, what you are finding out about the patients in op notes may in fact not be entirely accurate. And so you kind of have to jive what's in an operative note on a recurrent hernia patient with what you're seeing on a CT scan in terms of their recurrence. Okay. And that's part of the art of doing the preoperative workup for a hernia patient. The second point I want to make is when people have mesh removed, you would be surprised what someone thinks a complete mesh removal is versus what you think a complete mesh removal is. And I have been surprised on more than one occasion in my career to find that someone who had a complete mesh removal for infection still has large amounts of mesh in them because someone took out the unincorporated infected portions and left the rest of it behind. Okay. And so I would say that in this patient situation that you're describing, where someone has a previous infected mesh, even if you have an op note that says that the previous mesh was completely removed, you should be super suspicious that you're going to find some mesh behind, especially if on the scan you're seeing things that make you think that, like an area where there are non-anatomic folds and wrinkles, or a thickened abdominal wall, or if it was a mesh that has EPTFE in it, that's pretty easy to find. Okay. So remember that complete mesh removal for you and me as hernia surgeons is very different than somebody else's complete mesh removal. Okay.
Thank you so much, Dr. Powell. Having been here for only a couple of months, and I trained at Creighton, I have realized sometimes I will say even instruments. I will ask for an instrument and nobody knows what. Well, some people they will know, but the options they depend on locations and even the time, as you are saying, our evolution that we have had here. So starting back in 2005, we were trying to use, we were using bone anchors to fix if it's mostly to the pubis, but also if it's lateral or hernias down to the iliac crest. I know there's some conflicting information with that smoking cessation. That patient who quit a little bit soon, 4 to 6 weeks, they can have increased complications, not just pulmonary, but here we've been abstaining. In fact, if there is a doubt, we'll check urine just because objective information. It's objective information. Either something is made of PGA or it's not. Beyond which brand somebody else might have said. Nicotine, there's a little bit of a bias. Who do we get to test and who do not get to test? But that's the art of our practice. I mentioned earlier about the issue with anterior mesh placement, anterior being in an anatomical sense. You are too close to the atmosphere, and so our subfascia plane, or even suprafascia, but the plane that is in contact with the meshes, the drain we have there, we keep it while the patient is in the hospital. But no matter how much that it's evacuating, we'll make sure that it's removed because once the patient is at home, we are not entirely sure what else they might bring in contact with the mesh. Uh, we've been using the wound vacuum for lots of reasons. It's the data, it shows patients are getting better and better. We mentioned about meshes already. I think and I hope most places are getting past the adage of an open belly with multiple take backs for a patient who is not on pressors. Diabetes, I'm impressed by how patients are using, whether it's just high protein, low carbohydrate diet, or some of the medication adjunct. We talked about areas of that are naturally weak. If you can reduce any amount of pressure you put on it, whether it's visceral fat or ventral wall, weight loss, it goes miles. The synthetic mesh versus biologic versus in a contaminated field, I think that's the standard of care.
Innocent, would you mind going back one slide and we can
Not at all.
kind of talk about some of these? Hernia is fun because if you ask, 10 hernia surgeons their opinions about some of these things, you'll get 12 answers. Okay. And, so some of these things are, while they work, right? You have data to show they work. They're also not, universal truths about hernia surgery for other folks. And I'm going to just contrast some of the things that you have here with kind of how our hernia program works. And I think the main point of showing the contrast is just to emphasize that if you are, I think, a good hernia surgeon technically, a lot of the things that I think are dogma and you think are dogma that are totally different, we still have good results. Okay. So I'll start at the very top, which is, the bone anchor stuff. I have never in my life as a abdominal wall surgeon felt obligated to place a bone anchor when I had wide mesh overlap. And one of the things that you're going to talk about, I know later on about one of the advantages of the preperitoneal plane is about having wide overlap. In almost all patients, you can find some room for the mesh. The shortest spot for overlap in a sublay mesh placement is in the retropubic space, because the urinary bladder, the prostate, and the urethra show up. But everywhere else, hips, spine, rib cage, costal margin, xiphoid, you can make that preperitoneal plane go pretty far. Okay. And so I think if you have wide overlap, and again, you can get that in most patients, you probably don't need bone anchors. If you don't have that overlap, then something to fixate the mesh becomes more important. We are heavy proponents about smoking cessation. We agree with that for sure. And you alluded to the fact that there is data from the world of hernia that says it doesn't matter. And, again, that data was generated from the ACHQC. And I think what we know from every other branch of surgery that smoking matters and outcomes are less good when you smoke. And so if you take a step back and you ask, well, how the heck is it that hernia somehow doesn't matter? Okay. And I think it really, what matters is most of the patients in those series are being done at complex hernia centers where the surgeons are technically pretty spot on. They're doing retromuscular, either preperitoneal or truly retromuscular hernia repair in a sublay plane. And they're managing a lot of other risk factors like hemoglobin A1C. And I would just caution people to say that your results may vary. If you don't do those things, if you just say smoking, I got a paper here that says smoking doesn't matter, your results may vary for sure. We definitely do the weight loss for obesity patients. And I think your program, like ours, sends a lot of people over to get weight loss operations with our weight loss surgeons before we do their operations. There's a lot behind it. Some of it is just the physics of the repair. You talked about tension across the midline. And obviously, for loss of domain patients, it becomes very, very important to have some place to put the organs back on the inside. The full mesh excision for infected meshes, I think you're implying about post-operatively if a mesh becomes infected. And again, I think that there are many folks out there who might challenge that a little bit to say, if a reduced weight macroporous monofilament mesh is in a sublay space and gets infected, must I take it out? And I would say the answer is, it depends. Okay. I think that if you are comfortable managing that and you and the patient have an understanding that we might clear this infection now and think everything is great, and then it could come back 10 years down the road. You're having a discussion of immediate failure of the hernia because we're taking the mesh out versus salvaging the repair but leaving you with the risk of a mesh infection. So I think, there's some debate, I would say, in that regard. And what I do at my practice is different than what you guys do, is different than what the next group down the road might do. Just lastly, in the interest of time, kind of moving on, which is no synthetic mesh use in contaminated cases. And again, I would say that this is an area where your experience is going to vary quite differently at Carolinas from what other groups are doing. My group and Yuri Nowitzki's group and other folks have kind of looked at this both retrospectively, and there have been a number of prospective series looking at this as well. And those series suggest that biologic meshes, you're saying no synthetic mesh. I just want to let everybody know, what I think you're implying is we use biologic meshes in those circumstances, right?
Yeah. Yes. No.
Yeah. There are several studies now that show, both retrospectively and in prospective series, that retromuscular or sublay mesh in the preperitoneal space that is macroporous and monofilament outperforms biologic meshes in those same circumstances. And again, all I'm going to say is your results may vary. Okay. And so if you're a surgeon meeting somebody and you're talking about putting mesh in a contaminated case, you've got some evidence on both sides of the spectrum about, what to do. Should I do it? Should I not? Do you believe the Carolinas data, or do you believe, Mike Rosen's data? And the answer is you can believe both of those data sets because they're both accurate to the experience of those surgeons. Okay. I think you just need to understand that, there is data to support the use of synthetic mesh in contaminated cases as well.
Yep. Thank you so much for that discussion. And just to quickly circle back on something, the very first point about like the bone anchor, I was centered, as you know, as most of you as well. It's we see patients that are tertiary, quaternary referral because somebody has done this, and so the operative not comment could not have been more spot on. So I will spare some of these remaining points in interest of time, but like some of these, I think they're sort of becoming universal. The evidence, the pathophysiology, it might be a little bit not quite clear, but for one reason or another, the more the mesh is transferred around in contact with the skin, manipulated, the worse off it tends to perform. And if any failure that lots of good surgeons get to that is technically what good surgeons like technical in the OR. It unfortunately starts in the clinic. So we are seeing huge benefit rehabilitating patients, but also having our geriatric colleagues join us later, see the patient in the same clinic, in the same room before any trouble happens, so we can risk stratify and optimize the patient. So finally, to the actual topic that we're talking about today. I don't, uh, I don't know if you can see my cursor, but what I wanted to point out, and Dr. Powell was very kind to mention, if we go in the subcutaneous tissue, I'm not entirely sure why we would cut off all of the perforator and we are inviting skin necrosis. We can still get some blood supply back here, but only meshes once we get to the linear semilunalis, then there is a fusion, and we don't have much more that to go lateral. You can force it, but now we are inviting paramedian hernias from forming. So if you follow any of these tissue plane, only one in, the main advantage of this tissue preperitoneal plane, I feel like that is a wrong name, and I hope it's going to become clear. You can stretch from subxiphoid down into the pelvis, the pelvic floor, and as lateral as to posterior to girotas. So earlier I said we have not found how to create a new ventral wall. I think this is as far as we can almost get, uh, because mechanically, unless it's hard to just to explain how the intra-abdominal content are going to push through uh, a type of prosthesis that is widely draping in this site. Now, the fear usually has been not being able to dissect that far, and I hope you are going to find these feasible. And that's why I put these steps here uh, with some high, I don't know if they're highlight or retraction. So you have if we're going to do a preperitoneal repair, any resident, any fellow can jump in. Once you have the hernia sac reduced, the posterior rectus sheath is going to be in one anatomical location to your mesh.
One of the fellows, Dr. Sharad. Last name. Dr. Martinez.
Innocent, I'm just, you're because you're preperitoneal, obviously the posterior sheath is above your mesh.
Thank you so much. So the posterior sheath, we don't touch it. Protect it. We are way posterior to it, and even excuse my spelling, as much as where we possibly can, the the transversalis fascia, you want to elevate it superficial to the mesh. Is in the inguinal hernia repair, I think it makes sense to almost any surgeon, even interns. The inferior epigastric, we want them to not be deep to the mesh. At least we are causing other trouble. And if you find yourself in that situation, it might mean you're on the wrong plane, you're on the retrorectus. This tends to happen particularly below the arcuate line. And then as you go lateral, another hint you might have, particularly if you are in the midline of the abdomen, as you go lateral into the preperitoneal plane, if you're you're starting to fuse just at the edge of the rectus and there's completely no plane, that might be another road marker that you might be a little bit superficial to the true plane. So it's really just the thin peritoneum. That's the plane so far we're able to identify that can stretch back to Girota's fascia and back anteriorly and in the other direction, as we mentioned. I hope. Uh, so I was I already did mention that, and I hope now that preperitoneal plane is just as intuitive as you can imagine. Uh, Again, in interest of time, in the past, what we have done, I'm going to. So we want over time, we looked at the patient. If they come to you, sure, uh, you are in the correct plane and you have any size of the mesh prosthesis completely overlapping. What if you cannot uh, close the fascia? And the other beauty of this technique, not separating the fascia of the rectus muscle, you are really recreating, for lack of a better word, the true linear elbow in the middle, which is now completely reinforced deeper. Uh, but there's sometimes a tendency to do multiple releases or even component separation. What we are finding is even the subcutaneous tissue flap elevation, that in itself sometimes can gain you a few centimeters. But if you really have to stretch a little bit more, the transversus abdominis, the TAR, it's much easier to do just because it's just one plane above you, just not the vessel that I did mention. You don't want to take them. Back to the point for Dr. Pauli, uh, all of this, what I'm saying, it's going to depend on what is your local practices and where you trained. So depending on all of these factors, what you have available. If you are the VA, there's a specific contract, and in other region, it's the resources that are available. That's what you'd use. But these principles we are discussing, I think they still apply. And that gentleman we started with the 63 years old now, he's 15 by 15 centimeter fascia defect. You was able to repair these, so I guess now they are done. And there will be no issues. But if you wherever you create a plane, the body tends to fill that cavity with some fluids. And the patient will come to the ED for one reason or another. It's like they get scanned before they can even enter the emergency department. Sometimes it seems like. So the reason I put his image here, this is a patient I had done the repair we are talking about for them. You can see where the mesh is tenting up this fluid. Of course, this is together with the peritoneum that is underneath. Interestingly, a radiologist said this is an intra-abdominal collection. Uh, this patient was scanned in the usual scan position. They were not suspended down. So I was curious what anybody might make of how these meniscus came to be.
So, Eric, can I just jump in and just generate some conflict over here? So, do
Please.
you think so? I'm a fan of and I guess my first question for you in the group is, should we be using the term hernia? Because I really think that this has the implication that it's a straightforward boom, boom, done. And really, well, don't you think we should be using the term abdominal wall reconstruction? Because you're really trying to medialize the components. You're trying to restore, as the Hernia Society calls, core health.
Yeah, I mean this, this is part of the challenge of the world of hernia. I mean, I don't look at this problem really as any different than other surgical specialties where the diseases that everyone of us manage span from very simple to very complex, and oftentimes the same word is used to, to describe it, right? I mean, you might do a liver resection and you might do a liver resection, right?
Yeah.
I'm going to do a small subsegmental or non-anatomic wedge versus, a hepatectomy, a hemihepatectomy, and they're both liver resections. And this is really where it becomes challenging for insurance companies, for patients, for referring providers
Right.
to
And I
understand,
think, yeah, I think for the fellows to understand, I mean, it's ridiculous because to document what you do for a major complex abdominal wall reconstruction and, is challenging in order to get paid for that, right? So that's my number one question. And the second thing is with my initial love of being a plastic surgeon, hashtag Dr. Benzi can tell you, I love to add in an abdominoplasty or something to help with the excess skin in a lot of these patients. So I tend to do these myself just because it's such a expense for the patients usually. And so I'm going to say, and this is really controversial, but I'm going to say I use biologic, I use it intraperitoneally, and I resect excess skin. And usually we don't have an issue with blood supply or oh, and again, like you said, this is your personal data, so it's a little bit difficult. And most of the patients that we deal with are obviously multiple, kind of similar to you, Innocent, referred because everything else has failed. Is that wrong, Dr. Pauly?
I mean, if it's working, it's like here's
Politically correct, but I want to generate some controversy because
well,
I think it's
here's
important for our fellows to hear this.
one of the things that I tell people when they hear that Surgeon X does something that is so radically different than what other people do. And in general, what I usually say is if a reasonable person is doing something and they continue to do it, it's probably because it's working in their hands. And it may be very different than what I do, but if it's working, is it wrong? And the answer is no, it's not wrong. Now, we also do know, however, that hernia patients do doctor shop a fair bit, right? And so, maybe your patients are having hernia recurrences and they are going to someone else to have them fixed. Um, Dr. Birangara, do you know where that patient actually originated from? Do you know what hospital they came from?
Yeah, so
It wasn't Dr. Jerariah's patient. That's what I'm saying.
well, if he's in Louisiana and it was
so, so here's what I would say, Jerariah, Dr. Jerariah, is a couple things. In terms of biologic meshes, there's a good track record of them working, and there are now two groups on the call who prefer them. They are crazy expensive.
Yes.
So you're going to use 1 square foot of a biologic mesh, and I could probably do 120 hernia surgeries for the same amount of money that it would take for me to use one biologic or one permanent synthetic mesh. But obviously, my mesh requires me to do additional work to do. I do retrorectus TAR. I don't do preperitoneal operations. So I'm doing some amount of abdominal wall deconstruction. Um, and that obviously increases the risk of postoperative problems from component separations. But I'm saving money using a completely uncoated mesh in those circumstances, right? So it's not wrong. What you're doing is definitely um, costs more than what I'm doing to fix maybe a similar hernia. In terms of soft tissue work, uh, you know Dr. Mirangaro said we don't like to raise skin flaps up because of the risk of wound problems and complications. That's true, but also if you've optimized your patient, they're a non-smoker, you've managed their weight, they're not diabetic, you know, raising skin flaps up to advance tissue medially to allow external oblique component separation, whether that's a perforator sparing or non-perforator sparing. While there is a morbidity to doing those things, those morbidities are, they're able to be calculated and in some fashion mitigated. What you're doing by doing a paniculectomy is raising up some skin, but you're also resecting the area most at risk for necrosis. And I know that the Carolinas group does that a fair bit, right, Dr. Birangara? How many paniculectomies have you done with Dr. Augenstein this year? I mean, you must have done a couple of them, yeah?
Yeah, we do. And in fact, if I said not elevating I would have misspoken. So I'm on the same page with you. We are on the same page with you.
Actually, Dr. Benzi wrote a paper on this, looking at the upside down tummy tuck for right subcostals, where we pull up rather than pull down. And it actually works pretty well, but you're absolutely right. It's more work, it's raising flaps, but you resect the sac. So no, thank you. What do you think about onlay position? Because I've seen that done, and I just wanted to know what your thoughts were with regard to onlay. For me, the idea is to take tension off the midline. That's my aim in these hernias so that I can allow tissue to heal without tension. But what is your thought, Dr. Pauly, about onlay?
Yeah, so we use onlay as part of the spectrum of our hernia care. Okay. I would say that probably the biggest proponent for onlay repair in the US is Guy Veller from Tennessee, who does sort of a Chauvel style onlay where he closes fascia, he raises skin flaps, he places mesh in an onlay position. He uses skin staples to hold the mesh in place. He uses fibrin sealant to sort of glue the mesh to the fascia, and then he places some drains. And he does that in a variety of different contaminated situations, including infected wounds. He's using a macroporous monofilament polypropylene mesh, which is pretty resistant to contamination, and his results are very reasonable. Okay. What I would say is, for all of the reasons that have been articulated, I don't like skin flaps. I don't like onlay mesh. We like sublay with wider overlap. But I absolutely use onlay mesh in a variety of circumstances. The two main places that I use it are peristomal repairs, where I'm doing sort of a not my A number one repair. Okay. I don't want to go intra-abdominal on the patient. I'm going to close the fascia and I'm going to place a mesh in an onlay fashion somehow. Onlay keyhole, onlay cruciate. Or if I meet somebody who their abdominal wall or their abdomen is kind of it's a no-go zone on the inside. And I have a pretty high threshold for what a no-go zone is. Okay. I'm talking frozen. Then the onlay space is where you're going to get the mesh. And if I've already done a TAR or a big sublay preperitoneal repair, and somebody has fractured their mesh and has a recurrence, we usually use onlay as our next go-to before redoing the sublay space. Close the fascia, place an onlay mesh, kick the can down the road, and if it lasts, it lasts, but you've at least deferred them having a redo retromuscular repair for some period of time.
Thank you. That's really, really helpful and beautifully summarized. So I really, really appreciate it. I just think it's important for the group to understand that there are nuances to all of this. And,
I, I,
and
there there are absolutely nuances, but I think that if you want to be really good at hernia surgery, you got to have like these are the repairs we do most of the time, but having these like your backup plan to your backup plan, like because you're going to wind up down that pathway some way, no matter how good you are at fixing hernias. I've got a lady that I have an entire hour-long presentation on about all the ways that I kind of did stuff wrong on her, and every move that I made, she made the exact opposite move. But you got to have your next step in mind. You got to be, how do I say it? Like a carpenter building a flight of stairs. You got to be thinking one step ahead.
Love it. Dr.
And
Benzi, we have 5 minutes left. Do you want to? Sorry, I jumped in there to generate some controversy. Only I can do that, right?
Well, that's why we have you here. I appreciate it, Dr. Terasha. You want to just fast forward 2 slides to your AI topic? I think that's
well,
yeah.
there is not a whole lot on it. Beyond that, it does misspell things, and this was supposed to be the progressive. It, it's data involving about 1,800 patients over outcome over a span of 18 years. And with those changes that I listed a while ago, these are how our outcomes have been improving. But AI got it terribly. So I think it's great at some stuff. These the graphs, they look beautiful, but what they actually mean and the actual outcome, it's not this graphical representation. It's not accurate. So that's the entirety of my use for it. To the ask,
Innocent,
yes,
if
sir.
I could just say one thing, I would say that your local group has done some of the pioneering work on AI in hernia, and I would point to Dr. Henneford's work in machine learning for the interpretation of imaging studies. And I don't think you have slides on that here, do you?
No, no, I do not. But the thread right processing
That's okay.
that work, it's right, yeah, next to me.
Yeah.
I
Well, I guess what I would just say is, Todd's group basically looked at CT scans of patients who were going to have hernias, and they asked a deep learning matrix to predict outcomes. Will this patient have a pulmonary complication, a wound complication? Will they need a component separation? And like all kind of machine learning, they gave it some trial runs. They said, hey, this person got a wound complication. This person needed a component separation. And so they did a training session, and then they did a testing session. And the deep learning matrix, and no one knows what it's looking at in CAT scans. No one has any idea what is it looking at. Was actually better able to predict some of the outcomes, like the need for a component separation, better than a surgeon, right? So expert surgeons could not predict as well as the machine the need for component separation. So I think that we are at the very dawn of our use of artificial intelligence for many things surgical, including many things hernia related.
certainly. So we're feeding it our data, and this is my last point. As you can see, just from talking about the preperitoneal space, we generated so much discussion. I wish we had more time to continue the talk. Uh, the last thing I did not catch the other doctor that is practicing with abdominoplasty as well. Think that not raising the tissue flap thing, it's for this patient, essentially, the mesh extends down into the iliacs and on the side, rather, whereas in the in the overlay fashion, once you get to the iliac crest, so like for patients who have had renal transplant and then getting referred to you or for whatever reason, then there's not much that you can reinforce in that direction. But I agree the parastoma and what you do as well. If it's a medial midline hernia, certainly it would be well reinforced. So I thank you all for listening to my ramblings. The actual objective data, it's the part that was remaining. But I think the discussion was much more enriching than you all hearing me uh, ramble on. And I thank you so much for your time.
Excellent. Thank you so much. Thank you so much, Dr. Pauly, for being our moderator extraordinaire. And everyone stay tuned. November 10th is actually our next session. And the topic is superior mesenteric artery syndrome and median arcuate ligament syndrome. Anyone that would like to be in our picture for social media, if you could please put your camera on right now.